All right, we're going to talk a little about some high-risk postpartum. Certainly, I'll try to keep to some of the more, I guess they're all important. That's my problem, is that I think they're all important. But some things you might see, say, on the final exam. First one being deep vein thrombosis. That's probably, as I mentioned before, pregnant women and certainly postpartum women, in the first 2 weeks at least, are at higher risk for DVT. Their coagulation factors are slightly off, increased. It's related to inflammation, that sort of thing. That's why we're getting moms up and moving right away, practically. We're putting on the stockings, the pneumatic stockings, if you will, on the OR table for the C-section before they even get anesthesia. And they're on for the first 24 hours, but we're getting C-section patients up within 6 hours of surgery, and we're getting them moving, just like vaginal deliveries as well. I had a patient the other day who was on magnesium sulfate for extremely high blood pressure. Postpartum, she was, and the medication was making her feel pretty lousy. And she was in the bed. She had to start getting up and going to the bathroom, which is good. She was losing a lot of the swelling, but she was otherwise in bed for her own safety, and we had the stockings on her because we weren't going to be taking any of those chances. All right, so deep vein thrombosis is probably, I would like to think, the most common complication postpartum. But it certainly has decreased because of all of these efforts of early ambulation. You're going to have people who are at higher risk, naturally. These people are at higher risk outside of pregnancy also. So, what you're going to see is leg pain and tenderness, swelling, warmth and redness, one-sided, right? I always tell my patients, I'm looking for swelling, and I'll say swelling is normal postpartum, as long as it's equal on both sides. You'll see, if one side is way more swollen than the other, if you have a red, hot, hard spot in one of your calves, that sort of thing, that's an issue. Holman sign is when you flex your feet, you might feel a pain, like a stabbing, sharp pain in your calf. That is a positive Holman sign. We can diagnose with Doppler ultrasound, blood flow study, CT or MRI. What are we going to do? Hopefully just prevent it so we don't have to have it happen. But once it is diagnosed, we're going to rest. We're going to elevate that extremity. We're going to do warm, moist compresses. We are not going to massage the area. Just think, we don't want to break it up and send it to the lung, right? Exactly.
So would you, they're not getting heparin because of is it, all right, no, I'm sorry, postpartum. We wouldn't
Postpartum, we're giving them heparin.
Okay.
Yeah, we are. Yep.
But before the baby, no.
Lovenox. Most every post-op C-section patient nowadays is getting Lovenox for the first 48 hours or so. Yeah.
For what?
To prevent
Before
DVTs.
or after, you said?
After,
Oh, the low first 48 hours.
yeah. So we're going to give heparin. Yep. So we're going to elevate. We can do, so they get heparin while they're in the hospital, and then they get sent home on warfarin. The warfarin, we really are trying to avoid pregnancy in warfarin, so you just have to be careful. That's pretty much it. Warmth, remember, no massage. What did I say? That whole anti-embolism stocking might work. Oh gosh, no. Yeah. Avoid the avoid the NSAIDs, or an additional NSAID. Some might be put on, baby aspirin or something like that. We're going to measure the leg circumference just to see if it's decreasing or increasing, right? But the elevation and warmth and rest is the way to go. We got to watch out for, when they're being treated, got to watch out for the bleeding elsewhere, right? Warfarin and pregnancy, as I mentioned, don't mix. So if they're on warfarin, they need to be counseled to avoid, strongly counseled to avoid pregnancy. They'll probably be signing something that says they're going to use some sort of birth control, but not birth control pills, because that increases their risk of blood clots. So it's kind of a tough spot to be in. Yeah. There's some other things to avoid, and these are pretty standard for any patient on warfarin, right? Alcohol should be avoided, using a soft bristle toothbrush, avoiding prolonged sitting, that sort of thing.
Excessive spinach use.
Spinach use, what is it about, vitamin K?
Mm-hmm. For the
Mhm. Yeah.
What'd you say, spinach juice?
Spinach use. I said use, I was just being
Oh,
like
spinach.
excessive spinach intake.
But spinach juice sounds interesting.
I know, I was like, spinach juice. I can't hear him today.
Then you got your PE. All right, so that's the DVT gone wrong, right? Fragments of the clot dislodge and move into circulation. So that can be, I don't know, that's pretty scary to me. That's when I prefer to hide in the nursery. Just kidding. So we get the blood clot to the lungs. That's too bad. Same risk factors apply for DVT as opposed to a PE. Oftentimes they feel a pleuritic kind of chest pain. All right, they get a little apprehensive with some anxiety, certainly trouble breathing, breathing rapidly, distended neck vein. That's a pretty typical sign. They might have a fever, hypotension, and certainly decreased oxygen. There's your picture. Everyone needs a picture. Let's see. What are we gonna do for them? We're gonna find out what it is, and then we might have to go in and remove the clot, right? We definitely don't want the clot to hang around, so we just have to figure out how much circulation is being affected.
What's the XR?
Oh, chest x-ray, yeah. CXR is short for chest x-ray. So we're going to maintain semi-followers, head of the bed elevated, O2 by mask, and some sort of thrombolytic therapy to break up the clot. Alteplase or streptokinase come to mind. And you have your coagulopathies. ITP I think that is that's a underlying problem that often rears its ugly head during this time, this childbirth time. But DIC, disseminated intravascular coagulation. This coagulopathies, this is scary stuff. This is when all those coagulation factors are just they're going haywire, and you have oozing of blood in some places and clotting of blood in others. It's just very, very scary, I think. These are patients who are transferred to the intensive care unit for medical management, while obstetrics are called in to manage their OB care. And that's fine with me. I will drive down the road to the hospital, down the street, to take care of their OB care, as long as they're not in my unit. I just want the best for them, and I know I'd be too scared to give it to them. All right. So the ITP is certainly genetic, which we might not know about until this time, and then starts causing problems. There are certainly some risk factors for DIC, some of which we already talked about, that excessive blood loss and different things. Yeah, it's just scary all around. How we would manage it is, how would I manage it? I'd send them to the intensive care unit. That's how I would manage it. Postpartum hemorrhage, we talked about already, I know, I just want you to remember 500 milliliters or greater for vaginal delivery, 1,000 milliliters or greater for a C-section. We know the causes of hemorrhage, right? The uterine anatomy or lacerations. Postpartum hemorrhage could be an early one within the first 24 hours, often right all at once, or a late postpartum hemorrhage. This subinvolution of a uterus, all that means is the uterus is not going down that 1 to 2 centimeters every day the way it's supposed to. So it's still staying kind of big. That's maybe the confused uterus. That uterus that might have something kind of left behind, and it's not showing like a large amount of bleeding. It's just continued bleeding at the same rate as day 1 or day 2. That can add up to a postpartum hemorrhage. Bless you. So it's not as obvious as hearing blood rushing out of a woman. But once that blood is gone and they start going into shock-like symptoms, we got problems. So, yeah, got to do what we got to do. Get to the cause of the bleeding, right? Is it an old, tired, confused, pushed around uterus? Get to the cause. Is it some other reason? Get the doctor. We talked about the meds already also. Oxytocin, methergin. Can't be given with high blood pressure. Cytotec or misoprostol. Probably now, it's not probably, I would say definitely a drug way up there on the list for managing postpartum hemorrhage.
Mr. Misoprostol?
Misoprostol, yep.
Thank you.
And then we just have to either replace their blood or beef up their health so that they can replace their own blood. Oxygen levels might be decreased. If it's really that bad, we'd probably give them a blood replacement. But give them iron, protein, promote, healthy eating and different over-the-counter medications as well as dietary things that can help along the way. Have them rest. This is other cool thing, cool, I can't say very cool, but in the larger hospitals it's a little more possible. If what we've done, all the things that we've done medically are not working, they can use this balloon thing. It's a tamponade, really. So what happens is they put the balloon in and can put it up to like 500 milliliters of sterile water into it, and it's a balloon that fills up in the uterus and literally presses on the wound. Just how you would press on a wound externally, this is going in and pressing on the placenta site, hoping to stop the blood that way. A pressure dressing. The problem is they keep it in there for a long time, for at least 24 hours or something like that. But then it still doesn't necessarily, I don't know.
And what if I guess my concern with that is like, what if they're still bleeding, but that's blocking off it coming out, so it's filling up and you're only getting a small trickle out because that's blocking the
Right.
passage for it to come out?
Yeah, I think they're continued to be monitored very closely with this balloon in there. So they're being monitored, their blood levels are being monitored.
Ultrasound?
Probably, there's a way to see ultrasound probably. I betcha blood building up behind this balloon that's in there actually helps to help tamponade. But yeah, it's not necessarily the great thing. I have seen some women go for pelvic arterial embolization. They actually clot it off. Yeah, they might.
Cauterization?
Yeah, but they it's through interventional radiology. Yeah, they might have to the ligated uterine or hypogastric arteries. That's pretty serious stuff if you ask me.
I would think you wouldn't be able to have children after.
I was gonna say, does that affect their ability to have a successful pregnancy?
I can't imagine it wouldn't. You know what I mean? Like
Not that, but the other thing you were saying.
we've also had, no, they've gone on to have,
Oh, okay.
yeah. But cutting off the blood supply to the uterus kind of makes me feel like that uterus isn't not gonna. And I have seen women lose their uterus
Mm-hmm.
when the bleeding cannot be controlled. They have removed their uterus, which is pretty sad. Uterine anatomy, we know all about that. Not gonna go into it. Right? Old tired, push around uterus. Just gonna get to the cause and fix it. There's your picture. Express those clots. I told you about the eggplant, right? Yeah. Subinvolution of the uterus, as I had already mentioned. Why? Why is the uterus not going back down to pre-pregnant state at the rate that we would expect? Is it an infection? Is there a retained part of the placenta or amniotic sac that's confusing the uterus? And so we just have to get to the source of what the problem is, and will depend on how we treat it. Oftentimes, they'll go in and do a DNC, and then that takes care of the problem because it was a placenta left behind, and things get back under control. They might also do cultures to rule out any infection, endometritis being the infection I'm thinking. Guess we just got to figure out what the problem is and treat the problem. Certainly, they'll probably be on an extended period of oxytocin to try to get that uterine muscle to contract down more fully. Then you have the opposite problem. This is an inversion of the uterus. The inversion of the uterus is when the uterus actually comes out. So I've seen it, and it's not very pretty. Another good reason why we're pressing on the lower part of the belly before pressing on the fundus to support it, right? We have seen.
It comes out of the vagina.
Yes, it does. There's two things that come to mind for me. One is aggressive massage of the fundus can push the uterus literally inside out. The other is when the placenta is aggressively delivered, we'll say. So it may be that the placenta has an attachment issue. It sounds kind of funny, but is abnormally attached to the uterus, and they're tugging, and they're trying to get the placenta out, and the uterus kind of comes with it.
So does it kind of look like a prolapsed uterus
Is it
when
an
it comes out?
Absolutely, that,
Okay.
yeah. Yeah, it looks, what is this?
Yeah.
Doc, what is this? It appears to be this bluish red deflated balloon, when in fact, it's the woman's uterus. The inside of the woman's uterus, for that matter.
Would they be hemorrhaging?
They are not comfortable, and yes, there's quite a bit of extra bleeding. It's an emergency situation, by all means. What are we going to do? Yeah, pretty much. We push it back in, but then surgically they might go and repair the issue, especially if it's a placental issue, meaning the placenta is adhered and growing through the uterine wall. That's not coming out easily. No, women have lost their uterus that way too. So there's your pictures. Yeah, it's like could be life-threatening. Just think about it. So we're doing all this, and then we're pushing it back up there, and that just increases their risk of infection too, right? Yeah, yeah. They're not too pleased with the whole situation. They're going to be uncomfortable. They're certainly going to be losing blood and feeling pretty lousy. So we're going to put it back as best we can. But then figuring out, so they might have already gotten their Pitocin. We're turning that stuff off right away getting that uterus back up in there and then turning it back on. Yeah. Or we have to relax the uterus fully to try to get it back where it belongs. And then just treat the fallout, if you will, of the fallout. So retained placenta, it could be just a little piece left behind, or it could be that adherence issue with the placenta. But we know retained placenta leads to a confused uterus as well as increased risk of infection at a minimum, right? So you have your adherent issues. We don't exactly know why it happens, but there are degrees of adherence that are concerning, that may prove quite difficult. Placenta accreta is just a slight penetration into the myometrium. Most likely it will involve a D&C to actually get it out of the myometrium. And
Myometrium is the muscle,
it's the lining,
layer.
it's the lining and first layer basically of the, yeah. Then you have, it's basically the uterine wall, more than anything.
Okay.
Then you have the placenta increta, which is a deeper penetration into the myometrium. That's not coming out. That's not coming out with a D&C. And your placenta percreta, which actually not just goes through the myometrium, but penetrates and can attach to bowel in the, yeah. So that's a placenta that has penetrated through the myometrium and started attaching to other things within the abdominal cavity.
Would they know ahead of time that she had?
Nowadays, yes, we do
Okay.
know. Good. We might not know about the accreta, but most likely, if they've done ultrasounds, we will know about the increta and certainly the percreta. And these patients are generally scheduled for a C-hyst. We call it. So we do a cesarean and then a hysterectomy.
So that's their last baby.
That is indeed. Yep. Because there's no way to get these out.
What is that picture of?
That's the uterus
The uterus.
with the placenta,
Wrapped around it.
yeah, basically invading it.
It's like a
Yeah, alien. Look at
It's
this.
like
I'm like, yeah. So it's quite an operation, quite a surgery. We got OB in there to handle the C-section, and then we have general surgery team for the hysterectomy. We have blood bank on call for the potential, the very real potential of a postpartum hemorrhage throughout this whole process. Yeah. So we just have to handle what the retained placenta has caused, whether it's a decreased blood supply or, preferably not an infection or anything like that, but a good chance. And like I said, treat whatever it is that is a result of it. We know about lacerations, that tearing of the soft tissue. We know about those on the outside. Those are easier to find, but those ones on the inside might not be immediately obvious because there's vaginal bleeding. That those higher lacerations up by the cervix might go unnoticed at first because bleeding is bleeding and we might not notice. That's where the whole excessive bleeding but fundus is firm where we would expect it. That's when we should suspect that it's coming from somewhere else. So let that be a lesson to you. Then you got your small tears that have like within the soft tissue that can result in a hematoma. It's a collection of 250 to 500 milliliters of blood within the tissue. What I have seen, and probably the ATI authors have seen, is this bulging bluish mass that's coming out of the vagina. It doesn't look very big, but my gosh, is it causing trouble. These patients are anxious, and they are edgy, and they are complaining of a large amount of pressure and burning pain. Yeah, because there's 500 milliliters of blood within their tissue. We're just seeing the tip of the iceberg with this little bluish bulging mass on the outside. It's on the inside that all that blood is kind of backed up. Pain is their primary symptom, but I see also that anxiety along with it. Sometimes, again, it tamponades itself off. I just assume go in and get it taken care of because they don't want to have to put up with that kind of pain until it dissipates on its own. Yeah, drain it at least. Yeah, so that's what it looks like. It doesn't look, but yeah, that's not very pleasant. But you wouldn't expect that to cause so much pain. Guess again, that's the tip of the iceberg. There's a whole lot more blood behind that bluish little mass there. Yeah. So we're gonna go. I personally would push for relieving the pressure and ligating whatever vessels are causing the trouble. We know the risk factors for lacerations and hematomas. I will say that women with light skin, like the fair-skinned women, especially red-haired women, their tissues are less distensible, so they're easier to fray, if you will. I have seen fair-skinned redheads have terrible problems with their nipples in breastfeeding. They just get more easily broken. The skin just breaks down a whole lot easier. I saw I took care of a woman, it was really with students, so I didn't take care of her all by my own like I normally do. But she was clearly a fair-skinned redhead. And I was like, ooh. Whenever you ever see one of those coming along, you're like, oh, she's going to cause some sort of trouble. I'm not sure. Especially if they're still pregnant. We used to, back in the day when not everyone needed an IV, we would start an IV on those fair-skinned redheads because they're also more prone to postpartum hemorrhage. Anyways. So, those are the symptoms. We just have to manage them as best we can. Keep them focused. I just feel really bad for these people. And then you have some postpartum infections, endometritis, all of these infections. They feel pretty lousy, plain and simple. They feel like they have the flu, right? They might even have swollen glands and stuff like that. It just feels lousy. Gotta treat whatever the infection is. Fever is, as you probably already know, is 100.4 or higher, at least for 2 days. Past the initial postpartum period, within the 28 days. And I mean past the initial like milk coming in stage. What we don't want to happen is a postpartum infection turning septic, right? Because those are pretty sick people. So endometritis is the infection of the uterine lining. Usually occurs 48, 72 hours or so after birth. Basically where the placenta was attached, that's the wound, right? And then it spreads to the rest of the inside of the uterus. You could have a wound infection, and I'll be honest with you, I have rarely seen episiotomy or laceration, like perineal laceration wound infections. I would think that would be a pretty ripe place for an infection. I just haven't seen very many. I've seen plenty of C-section incision infections, yes.
I would think the episiotomy would be, maybe it's more prone when they're home.
No, because I worked in a doctor's office for 3 years.
Seeing them more than just
Or
saying.
maybe
Yep.
they're more conscious of it there, because
Yeah.
if they're doing 6 baths and.
I don't know. I just find it interesting. I would think that dark, damp.
Dairy bottle.
Yeah.
Probably
Oh my gosh, I love
dirty,
that
so you
thing.
clean it every time because there's major discomfort.
Maybe. I don't know. Witch hazel pads? Maybe. I don't know. I just haven't seen as as many, if any, episiotomy infections compared to
Like
Your
there's
teaching
some
is
normal
that
flora
surgical.
there, maybe keeps it clean.
There you go.
Teaching is
Yeah,
that
that might be it.
on your back.
Normal flora, I don't know.
Normal flora, the
Acidity.
acidity. That was the other thing I was thinking. Maybe the environment isn't as friendly
Yeah.
for infection as I initially thought.
Yeah.
Your mastitis. Mastitis is an infection of the breast. Usually it's on one side versus both sides. It happens after milk supply and everything is established, all right? So after the 2-week mark, anyways, in the breast, it's most often Staph aureus. Gosh, they feel lousy. They feel really, really lousy with the mastitis. We have your risk factors for infections there. Mastitis can start as a plugged milk duct and then just get infected. You can look at the difference, and I think I talked a little bit about this back in the postpartum business. The difference between engorgement, which is bilateral. A plugged milk duct is usually on one side with like a certain spot that is the most tender. And then mastitis, which is usually one side, more generalized on that breast, and really flu-like symptoms, feeling that lousy. There's certainly risk factors, including poor breastfeeding and, like poor hygiene. So treat the infection, plain and simple. Find out what's causing it and working through it. I think that's, I think this is important to know, not necessarily for the final, but it's especially if you are yourself of childbearing age or somebody you know, God bless you, to be able to differentiate between engorgement, a plugged milk duct, and mastitis is a pretty good thing to, you could have a patient in your line of work that's not an OB patient, but they're breastfeeding. So being able to recognize the difference between the three is, I think.
Well, that's the one on the chart, right?
On the chart? On the chart, thank you very much. Here's your picture, if you need one, of a pretty sore, sick booby. UTI, you can imagine, I'm surprised it doesn't happen for everyone. All the activity down there and what's going on, right? But a UTI is a UTI, and certainly they're at higher risk postpartum. That's all your business there, all right? E. coli being number one. We talked already about postpartum depression. It cannot be stressed enough, in my opinion. Remember, they're most likely not going to speak up on their own. So asking them point blank if they're feeling depressed is important. Maybe not using words like depressed, but actually describing what that might look like or feel like is important. And overall, ensuring their safety, making sure that they have somebody looking over them, looking out for them. And it becomes an emergency if they have any thoughts of suicide or of harming themselves or their baby. It is, infanticide, right? Suicide or infanticide. We really need to get them help immediately. Postpartum psychosis, it's real and it's scary. And I think that's pretty much it, right? Yep, amen.